So I might just open up by saying that I'm an AME. So
Sure.
there's a process for becoming an AME. You're a general doctor, and then you do some sort of postgraduate training. You could be a GP, for example, but it could be any specialty really. You have to have kind of a demonstrated interest in aviation. I think in the old days, you used to actually have a PPL as minimum to become an aviation doctor. They might have relaxed that recently because there's a huge shortage of aviation doctors. And you had to do various courses. So those courses are quite long and there's exams and they're quite expensive. And I think that's deterred a lot of doctors from becoming involved in aviation medicine, which is a shame because there's now a national shortage and pilots can find it quite hard to get a medical.
Sure.
The main structure is that for commercial flying, you'll get a class 1 initial. That's the technical term for it. So class 1's commercial, and the initial medical is a big deal because there's a lot more tests than you'll get in the renewal medicals. And if you get the initial medical right, the renewal medical should be absolutely straightforward unless the person develops a new medical condition. But if the initial medical's done badly, if something's missed out, not done properly, then that pilot can find themselves grounded when they're coming to the renewal through no fault of their own, midway through their training. So there's a lot of responsibility in doing the class 1 initial correctly. And for that reason, it can only be done in designated centres. So we've got Heathrow Medical Centre where I work. We've got another one at Centreline in central London, and we've got Birmingham. There used to be one at Prestwick in Scotland, but there's only 3 now. And we're doing the work that the CAA used to do at Gatwick, at the Civil Aviation Authority headquarters. So the medical we do is quite extensive. We managed to do 6 a day, but as you've noticed, we sometimes overrun because things are a bit more complicated than we expect. You've just got to take the time it takes. So I assume that most of the audience are people who are thinking of a commercial career and
that's correct,
would be thinking of a class 1 initial medical. Is that right?
That's correct, Dr. Pitts. Yeah, that's exactly the case today.
So it might be just like if anybody's got questions about the process for getting
Sure, there was 2 in the chat. So someone was asking, how much does your close family member's health and condition play into you gaining a class 1 medical?
Okay, so again, just keeping it general and confidential. Sure. When you do your application, you make a declaration on CELMA. So you register with the Civil Aviation Authority as a customer, and that entitles you to use the CELMA system. And you make an application, and there's a series of questions. And the second half of the questions are actually about family history. So people answer these with varying degrees of accuracy or conscientiousness. And they often wonder, to what extent should they, how big is a family? I mean, you could have hundreds of people in your family, right? If you take it to the distant relatives. So I generally, rule of thumb, say mum, dad, brother, sister, and then the major stuff. So it would be, with stuff we're interested in is like heart disease, high cholesterol, glaucoma, which is an eye thing, which can affect your vision. And from the doctor's point of view, it just gives us an idea. So if that person, for example, themselves has a high cholesterol, and then you look at the CELMA application, oh, your dad had high cholesterol as well. It's possible that that person then has an inherited form of cholesterol problem, and they're more likely to get heart attacks and strokes as they get older. And so it shifts the emphasis for us towards preventing that, to saying to the person, you need to take expert advice on this. You need to decide about diet or medications while you're young to save you getting into the problems that your dad is now facing because dad has had a heart attack or a bypass operation or something. So we're kind of trying to build in some prevention into it. But there's no bar. So there's no question that person would be denied the medical.
Makes sense. Yeah.
So we're hoping that people will just kind of divulge the useful stuff without fear that it will stop them getting a medical.
Yeah, I think amongst the community is definitely a point of discussion, that the fear aspect. A lot of us potentially fear coming to do a class 1 and fear being deferred or having to do extra consultation or whatever it may be. So in terms of what are the essential steps we should be taking to kind of essentially get a class 1, or before we come to apply to get a class 1, what essential steps do you recommend taking?
Okay, so it's just very important to understand the truth, because there are a lot of rumors spinning around, and you see them. I mean, I'll occasionally look at the pilot forums. Don't tell them you've got your dad had a heart attack because they won't give you the medical. There's a lot of misinformation. So the truth is, if you divulge the relevant conditions, say for example you had asthma as a child, what that means is, if you tick that box, you've told the truth, you're going to be worked up for the asthma, and that means a bit more expense and maybe a bit more delay, because there's a mandatory referral. In other words, it's not me or Heathrow Medical, it's a law.
Right.
So we're dealing with the law here.
Yeah.
There's a law that if you declare the asthma, you have to see a chest specialist.
Yeah.
And I don't know if people get that these rules tend to have a basis in safety. So I don't know, just to ask the audience, in case anyone knows or can work out why asthma might be important in a commercial pilot. What is it? What's the real safety risk? Because all of this is about safety. What's the worry?
Yeah, we were actually talking about this before. I mean, yeah, that's very true. So I guess any condition that can potentially interfere with the safety of an operation of an aircraft, that could potentially be an issue, would you say?
Yes. There's a specific thing with asthma though. So lots of people have asthma and they play football and they live normal lives. So you think, well, they should be able to fly a plane then. Like, what's the big deal?
Sure.
But can you think what it is?
Yeah, well, what do you guys
I'm not
think?
targeting anyone, and I'm just throwing that question open.
Sure.
See if anyone can work it out.
Yeah, sure. What do you guys think?
It's Chris W here. I don't know if you can hear me.
I can hear you, yeah.
Yeah, you can hear me.
Chris.
Hi, John. I'd say the main risks, the two that I can think of, are if there's a sudden decompression or if there's a fume event. Those are the two from an asthma.
Exactly. Yeah, that's right. So if there's a sudden decompression, spot on. The risk is that there's only a few seconds of consciousness in order to get the mask on. And if you then go into bronchospasm, which is an asthma attack, you've just got another serious thing to contend with. So you've probably got a misted cabin and the immediate shock reaction and fumbling for the mask and getting that on. If you, or indeed your co-pilot, is then suffering from an asthma attack, because we're really interested in reactive airways, it's called. It's the sort of person who would get their asthma if it was cold, or if it's a polluted atmosphere, or if it's exercise induced. That's what we're looking for. So the actual test we do tries to provoke asthma. And that's the real reason. So usually you can trace all of these rules, which might seem a bit over the top, back to specific things, and Chris has hit two nails on the head there. It's fume events and sudden decompression are the things we're really interested in. So you'll know these are things with a very small chance of happening, but disastrous consequences if they're not managed properly. So this is all about risk management. So that's just one example.
Makes sense, yeah. But what about if conditions, what regardless of what they are, what about if they are being managed or they have been stable over the years? What would you say to that?
Well, so I used to work at the Civil Aviation Authority. I was a medical assessor, and
Okay.
I know that the CAA would rather know about a condition and know that it was managed and know that it was supervised, the person's getting good treatment, and know that that person's honest enough to say, I've had a flare up. So we've got people flying with all sorts of quite severe medical conditions, but the assessment of the person is, say to give another example, somebody who's got inflammatory bowel disease, ulcerative colitis or Crohn's, right? Yep. They can fly, but if they have a flare up, we expect them to declare it.
Of course.
And we then protect that person because we will issue an unfit letter, which means they can't work till that flare up's cleared. And that protects them from employers who would just say, look, we're busy, you need to work. Because a lot of employers in a lot of spheres will do that. They just want the work done. Whereas in aviation, a responsible employer won't do that, of course, but somebody who's short-handed, they don't want to cancel a flight or do diversions, whatever, they just can't make that person work. So we protect them by giving them an unfit letter.
Yeah, that makes a lot of sense. Yeah, I mean, the main thing in aviation is safety, isn't it? And that's what you guys are always striving for, even when it comes to awarding Class 1 medicals and medicals and generals. But in terms of around the food around the subject of foods, what would you say are the rules around allergies and foods? Because they can, for example, be like the rules that they have with in-flight meals. And so what would you say is the rules surrounding food allergies?
Well, all of these rules are visible on the CAA website. So if you have a specific condition, and we find this here, sometimes the pilots will rock up and they say, I've got such and such condition, and I've done all the reports because I looked on the CAA website. I have to say it's rare, but it does happen because the information is all there in the public domain. So with food allergies are usually minor, but occasionally fatal. So there was a very heavily publicized incident at Gatwick Airport, Pret-a-Manger, where somebody took there was a substance in their sandwich that they were strongly allergic to, and to cut a long story short, they sadly died. So those people who have food allergies will often know about it, and they'll often carry an EpiPen where they inject themselves if they're getting the allergy. We do have pilots flying with EpiPens. So if the person has a strong food allergy, we'll see them and we'll identify the problem, usually because they'll tell us. And then we'll say to them, okay, you need to get an expert report. So you need to go and see an expert on that condition. And they'll try and drill down into it and work out how bad is it? What is it allergic to? Are the things avoidable? Is it treatable if you have an attack with an injection? If that expert says this person doesn't need an EpiPen, then they'll generally get a Class 1 initial, unrestricted. And if they do need an EpiPen, they would have to have a multi-crew limitation.
Yeah.
Okay. Now, there's a legal thing here where we can't, at the moment, issue Class 1 initials with a multi-crew. So that's when someone with an identified severe illness that's under control, they can only fly multi-crew. We can't legally issue those. But there
Makes
is a
sense.
way around it. There is a way around it. So the CAA have worked out a way of giving the person and it says on it SSL, ILA, NCAT, no commercial air transport. That allows them to do their training. It allows them to go solo for the solo phases of the training. And then when they come to renew, they get a Class 1 OML when they are seeking employment. So there's a loophole, if you like, that we can use to get people with severe allergies that are well monitored and well treated to fly. You'll all know about multi-crew cooperation. So those pilots have a brief that they're supposed to explain to their co-pilot that they have an allergic condition, and that in the event that they become ill, there should be two EpiPens in their flight bag that have to be administered. So it's there's nothing, I think, apart from sadly diabetes type 1, that's an absolute showstopper. People come to us with all sorts of medical issues, mental and physical, and we just do our best to put a good case forward to the CAA. When it's complex like that, we can't issue the certificate. So if someone comes here for a Class 1 initial and there's absolutely nothing, we can issue the certificate. Or if there's something minor, we can issue the certificate. But the case like that, we would just get everything perfect for the CAA to look at. That's all the reports uploaded, all the tests done, and we tell the CAA to look at the case. A week or two later, they'll either issue a certificate or they will say they need more information, or they will refuse to issue a certificate. It's a denial, it used to be called. I think it's called just unfit. You're unfit. In a sense, it's better to have an answer than no answer, because you can then appeal that. So there's 3 stages of appeal, and then you can take it to the House of Lords. It actually will go to the House of Lords if you take it that far. So there's a huge structure in place to make sure that it's fair. Actually, the last stage of the appeal is the court system.
Sure. Like you said, there's a lot of regulations, but you also get a lot of people that come to you with varied conditions and whatnot. But is there something that we can do as individuals to maintain a healthy balance, or what can we do to keep monitoring our health to potentially lower the side effects of potential future disqualifying factors?
So pilots as a group tend to be healthier than the general population. They tend to, because when somebody's being monitored and they're having an annual medical, they tend to look after themselves better. It's not invariable, but it's generally better. So those people will tend to not smoke, watch their diet, not drink too much, exercise regularly, see the doctor if they think there's a problem early on. They tend to be that sort of person who, with the ones coming into the profession anew, some of them have allowed themselves to get out of shape. So they've allowed themselves to become clinically obese. And if your BMI, your body mass index, is over 35, there's a whole load of extra tests to do, including a lot of cardiology and tests in the aircraft to make sure you're not too big to, like, you can reach all the controls, you can get out in an emergency and all this. So that all has to be tested. So we sometimes feel people, they come to a Class 1 initial and they fail because they're too big, right? But that's a kind of call to action to them. And when they come back next time, you see them, they've lost 20 kilos because they just realized, they've let themselves go and they can't pursue their dreams because they've not stayed fit.
Yeah, it makes sense. I guess a pilot's role is already difficult enough, sitting down many hours, a lot of stress. So keeping a healthy lifestyle and ensuring that you are keeping up with some form of exercise is also important, like you said. There is a lot of physical conditions that a lot of people are genuinely worried about. and yeah, there's a lot to do with food and whatnot. But what would you say around the realm of mental health, and can it be a disqualifying factor in terms of the anxiety and fatigue that people may have faced in the past?
So the mental health. The first thing to say about the mental health is it's a very hot topic.
Yeah, I would guess so.
It became hot when
the Germanwings accident.
The Germanwings.
Yeah.
So I don't know if everyone in the audience is aware of that, but that was basically a murder-suicide with aircraft as weapon.
Yeah.
So to simplify it, the person wanted to kill themselves, but they also wanted to take out a lot of other people with them, and it raised awareness of mental health problems in pilots, because we call that sort of thing a black swan event. It's just unforeseen.
Yeah.
So we assume that the two guys up the front want to get to the same destination as everyone else, and they're going to do it safely. But what if one of them, is almost unthinkable, wants to kill the other and crash the plane? It's almost unthinkable. The trouble is that it's very difficult to detect people like that in society. So I think there was a kind of knee-jerk reaction, and people said, "Oh, we got to do more mental health." And they said, "Okay, well, what can we do?" So we started doing drug and alcohol testing. That came in after Germanwings, even though drugs and alcohol weren't part of the picture. But it's just something that can be done. And there's a questionnaire to fill out, and there's a peer support group for pilots. He wasn't going to talk to someone in a peer support group. He was a murderer. He wasn't somebody suffering from a touch of anxiety. So detecting these very rare events, people have tried to predict medical models to try and predict who's going to commit suicide. And it's extremely difficult, because it can come out of nowhere. You would never have guessed there was a problem with that person. And it's very, very difficult. But then we've got another group of people who pitch up with to the medical, and they declare that they've previously taken an overdose, for example, or the doctor's examining them, sees lots of cuts on their arm because they've been cutting themselves. It's called deliberate self-harm. All of these people, it's not like medical's finished out, you're not getting it. All of these people are fairly assessed. So that person's as fairly assessed as the next person who doesn't have that history. So we have to get a report from a psychiatrist.
Right.
We have to then inform the CAA. Those ones are actually brought to the CAA, where there are, I think, 4 psychiatrists, very heavy duty psychiatrists, very experienced, all of them very interested in aviation, who will interview those people. And sometimes they will get their medical certificate, because it's judged that the risk is very low of that recurring. That makes sense. That everyone knows. Yeah.
In terms of if they have been well monitored, for example, and they have overcome their anxiety or their fear or whatever it is that may be, and they have been stable, and they have chosen to speak about their mental health issues openly, both with you at the CAA and both with, for example, personal psychologists or wherever it may be. If someone chooses to be open, I guess it helps them also receive support. And so, what about the people that have recovered and are fine in a sense? What would you say to that in terms of rewarding them with their Class 1 medical?
They'll get it.
Okay. Yeah,
So it's much better to have somebody who's open and honest than somebody who tries to conceal things. That's where the real danger lies.
Yeah, of course. Yeah,
they've concealed it not just from the doctor or the CA, but also their employer and their co-pilot and stuff like that. The safest people are the people who are externalizing things. They're saying, parents died, and then I slipped into depression, and I thought about ending my life, and I took 3 paracetamol, and I went to hospital, and now I know it was a totally crazy thing to do. I was so down at the time. That sort of person who's very open and honest is much safer than somebody who's just tight-lipped, won't discuss it, you know? And
Of course.
there are massive cultural differences in this. So we see pilots from all around the world, and in some cultures, it's zip, you can't discuss it. In other cultures, it's much more normal to externalize things. So we're kind of reading the signs here. Sometimes we get whistleblowers. So I don't know if you audience know about this, but sometimes we'll get a relative phoning in saying, my son's come up for, a pilot. He wants to be a commercial pilot. Did he tell you he tried to kill himself? We get that.
Right.
Can you believe it? And you get that a lot at the CAA.
Right.
My husband's driving to the airport and he's just drank a bottle of whiskey. So you get people with like concealed. So drugs and alcohol are actually a real problem because the pilot lifestyle, they're away from home and they get bored and they've got the money and they're loose ends, and some of them head for the gym and keep themselves healthy, but others head for the bar. And so drugs and alcohol are a big problem. So there's actually one of the psychiatrists at the CAA specializes in drug and alcohol in pilots and in doctors, would you believe? Because doctors also have a high instance of these problems. And then the third thing, just because we're talking about the serious stuff now, the self-harm, suicide, alcohol and drugs. The other thing about mental health is much more talked about now. So when I was a kid, nobody talked about it. Absolutely. And nowadays everyone's talking about it. So it's very unusual to get somebody coming along who's had nothing, right? Because loads of kids are put into counselling or given drugs for ADHD that there's actually nothing wrong with. So they've got to untangle all this. So they've got to bring all the educational reports and we have to upload them. The CAA psychologists have to look at them and all this. They say, like, why was this person given that label? Because it was just like at the time, their mum took them to see a private doctor and the private doctor says, oh, you've got autism. You need to come and see him every month for a year and it's 500 quid a time, right? Then that person's labeled as autistic. Next thing, they're mentally ill. Next thing, they've got to declare this. And it was when you go right back to the beginning, there was nothing. So we'll always try and untangle it. Was this a fair diagnosis? Absolutely. Or was it somehow motivated? Yeah. And there's a limit to what we can do. We have the huge advantage of talking to the person. But the CAA have the advantage of being able to step back from it and have lots of experts they can tap into. And all of these people who apply will get, I can guarantee you that because I worked at the CAA, they all get a fair crack of the whip. That is to say, they'll all get a fair assessment.
Absolutely.
Even with multiple medical problems, even with quite serious mental health issues, they'll all get a fair assessment. And if they don't like the assessment, they can appeal.
Yeah, it's always an option, isn't it? Yeah. I mean, we don't also need to forget that all of us student pilots, I think we sometimes forget that we are humans at the end of the day, and pilots are also humans. So mental health, like you said, it's a real thing, and I'm sure that myself and a lot of other people here are put a little bit more at ease at the fact that when you choose to speak about it or are open about it, there's ways that you can go ahead and solve things, isn't there? So being open about it.
I think you're absolutely right. Yeah. And I think we're getting better at that. And I understand the fear of people concealing medical conditions to get what they want, to follow their dreams. But what's not widely appreciated is actually a criminal offence to do that. Carries a 2-year jail sentence.
It is not. A lot of people know that. Yeah,
it is actually true. And the CAA can prosecute people. They rarely do. And I can't think of the last time they put someone in prison, right? But they do have the power to do that. Sure. So sometimes when we get audited as AMEs, are you telling the pilots this? Well, I don't tell the pilots that because most people are honest, but occasionally you'll get one say, like, there's nothing on your CELMA. Oh, well, I have migraine and I had a heart attack. And I say, hold on a second. Are you aware that that's a criminal offence? You're supposed to declare these things. So we better change your application and put them in. So I don't like to use that fear factor myself unless the person's coming at it from that angle. Most people, when they understand why. So I've got a couple of stories that illustrate this. I had a friend who's a pilot, and he was flying on a flight, and his co-pilot had an epileptic seizure. So he was not only dealing with the flight deck, but dealing with the ill colleague.
Sure.
And when the event, it all resolved itself. So a member of the flight crew came up. There was a doctor on board. They dealt with the seizing pilot. The other pilot managed the flight. The reason we have two pilots is in case one becomes incapacitated, and the other one should be able to complete the flight quite safely. And he did. He spoke to me and he said, I hate that guy. I hate him. Because he should have declared that. How dare he? So people will sometimes think, like, when they get more experience in flying, they become quite resentful of colleagues who don't tell the truth and then put them at risk by concealing these.
There
was another one. When I was at the CAA, we used to get the accident and incident reports, and there was this one. The first officer had a seizure, but his feet jammed on the controls. And they could not get him away from the controls. So the aircraft was going into a pitch oscillation, basically. And they called up, eventually, it was a steep climb to get to and then a steep descent. They got this guy, he was a rugby forward or something, to come up, and they prized this guy out of the controls. I think they broke a couple of bones in the process. And the other pilot regained control of the aircraft and landed safely. And when they did a search of the flight bag, they found the anti-epilepsy medication in the flight bag, but he's never declared that, and he'd had several medicals.
It's really dangerous. At the end of the day, you're putting your health, the health of your crew and the passengers at risk by potentially not declaring any medical history that you think is not necessary or whatever it is. So I think it also is important to be open about your medical history and whatever it is that potentially affects you, because the more you're open about it, the more help is given to you, right? By doctors and AMEs like yourselves.
I think, to me, honesty is the best policy. I mean, no one wants to go to jail, right? Number one. But also, you want to go into a career knowing that if you're spending all that money, you're likely to reach retirement age. So we've had people who've come in, say, with complex heart problems. They've had congenital heart disease, they're born with heart problems, and then they've had multiple surgical operations as a child. We're looking at people who would have died under normal circumstances as a baby, and they've survived. And this is called adult congenital heart disease. And there are some people with adult congenital heart disease flying who wouldn't even have been alive were it not for the surgeries. But they're safe now. Everything's kind of like safe. They've had to do a lot of extra work to get their class 1 initial. And it might be delayed a bit while all the cardiology is looked at, because the CAA has their own cardiologists as well. But then that person knows if they get the initial, they're going to sail through their career unless something else happens, right? Yeah. So they can go ahead and safely invest the money and the emotion in training, because no one wants to get chopped halfway through. So that's another reason to be honest. And what the lawyers at the CAA, the ones who do the enforcement, they come after the naughty pilots. So you've got 4 ex-police and 1 lawyer doing the prosecutions. And what they say is the people who lie about on the medical also lie about the airworthiness and about the flying hours. It's a pattern that the CAA don't like, of the sort of person who's untruthful about everything, not just medical, to get what they want. Yeah. Which is kind of sad, really.
It is, yeah.
You kind of feel sorry for people like that. But it's not fair on their colleagues
It isn't.
or the
It isn't.
passengers.
Yeah, yeah. There's also quite a few questions surrounding the subjects of hearing and eye surgery. So let's just cover the eye surgery ones first. What are the kind of policy surrounding eye surgery and problems with the eyes? What's your kind of opinion on it all?
So I'm actually by trade an eye doctor.
Oh, okay,
So
fantastic.
for many years, I was the CAA ophthalmologist. So if you were a pilot who, class one initial, or even an existing pilot, and you developed a problem, you would come and see me, and we would work out a solution. We'd ground the person, and they'd go and have surgery. As soon as they're safe again, they'd be back flying. So the CAA clinic shut down, and we tend to use external ophthalmologists now. So Mr. Dogood's one in central London, I'm another. If the pilots have got complex eye problems, they'll come and see us. And the same's true of anything, ENT or whatever. You want to see a specialist who knows a bit about aviation, knows how to write the reports, and puts at the end of the report something like, this condition's unlikely to recur, or this person is now safe in flight with low risk of incapacitation, that sort of thing. So all of the specialties have people who are you can use anyone in that specialty, but there are people who take an interest in aviation. And then the CAA have their own people in-house looking at these reports. I mean, I can be specific about things, because if you look on the CAA website, if you just look up CAA visual eye conditions, it's got guidance for everything virtually you can think of on there. So if you have a cataract operation, for example, I think it's currently 6 weeks off work, and then some tests to prove that your vision's back to normal. Should be better than normal, actually.
What about once? Sure, but what about once you're actually a pilot? If you want to get eye surgery, for example, what are the procedures around that? Let's say so a pilot who's already got a class one and is in a role within an airline. What are the policy if they need or require to have an eye surgery operation?
So the first step is contact your AME and say, I've developed a condition, or I've decided to have eye surgery. Can we look at the CAA rules together? And then they'll say, okay, well, for that particular operation, you need 6 weeks downtime and you need a report from the surgeon. And they say, okay, well, let's time the surgery so that I'm on holiday, or, at a convenient time, I'm not flying, or not time it when I'm going for job interviews or promotion or command courses or whatever. And then the best outcomes are where the pilot just discusses it with the AME, and the AME checks the rules, and then they have the surgery, and then the official process, we call it making somebody unfit. So we go on Selma and we tick the unfit box, and then we give that person a letter saying you're now unfit under the terms of the Air Navigation Order. You cannot act as pilot command of an aircraft. When we get the report in from the surgeon saying the surgery is successful, he's now off all his eye drops, then we'll issue a fit letter saying, that you're now fit to resume your duties. Your suspension is revoked, and all the evidence. So nowadays we just upload it. We used to send it in to CA, but we just upload it now to that pilot's record on Selma. So that goes for any operation. So it could be I recently had a pilot had a wrist operation.
Okay.
You get people having knee surgery, sporty types, getting their cartilage done or whatever. They're just grounded, made unfit, and then restored to fitness status. So that's in the ideal world. What's a problem if someone pitches up for a medical and they go, oh, 6 months ago I had an operation. Oh, did you declare it to anyone? No. Did you get any reports? No. And I say, okay, well, you're now grounded. But I'm flying to San Francisco tomorrow. Well, sorry, you're grounded, because you should have been grounded 6 months ago. And now we need to, I didn't ask for reports, right? So that's when it all goes inconvenient for everyone. So it's better just to call the AME and say, I need to have a knee operation or an eye operation. How are we going to play it? Just involve the AME.
Sure. Again, another big conversation that was going on amongst our group was also the subject of hearing and what disqualifying factors are basically ruled out on a class one, and yeah. So what potential?
So the hearing's interesting. Yeah. So here's the thing with hearing.
Yeah.
There's an audiogram, and so headphones play tones in the ears, and you can work out a graph of the hearing sensitivity. If you fail that, it's not the end of the day, because there's something that overrides that, which is called a functional hearing assessment. And in the old days, you used to go up in a plane, and the instructor would say, "Oh, you can hear me perfectly well." Nowadays, it's a wee bit more structured, and it can be done in a sim. There's a similar thing for air traffic controllers, and they'll say, turn right heading 230, and see what the person does, right? And see if they're actually making sense of it. And that's called a functional hearing assessment. So a normal functional hearing assessment will override an audiogram fail. But more than that, we want to know, why has the person got poor hearing? So it's sometimes easy to forget that it might not be benign. So there's a kind of brain tumor that classically presents with loss of hearing in one ear. So if we ever get a pilot and the audiogram's fine on one side and poor on the other side, we'll insist that they get a scan of their head as well, or the CEA will. We can't really insist. We'll advise.
Makes sense.
And just in case there's some, these are benign tumors, by the way. They're treatable if you detect them early. So there have been plenty of pilots that have come back to thank us for failing them, because they've discovered significant things that weren't obvious to them. The hearing's an interesting one, and it's constantly evolving as cochlear implants and stuff like that get better. The engineering around it's getting better. So the rules tend to change when the technology advances.
Yeah, of course. Like every medical condition, isn't there? There's always coming up with new cures, medicines, and yeah. I mean, like you said before, you get pilots coming to you with all sorts of medical conditions, and yeah, it's just quite. What is, in terms of the percentage? What would you say is the pass fail?
It's a fail is rare. It's very rare. Almost everything can be worked out, because it's all about risk mitigation. So say somebody comes and they've got a psychiatric history and asthma and a heart problem and that. So each one of those things needs worked up. And then if the CEA feel that the cumulative risk, so it's actually based on a paper on incapacitation risk and the 1% rule. So if you're flying multi-crew, if you do the maths, and the maths is in the paper, right? It's beyond me. But it's a big, long probability calculation. If the person's got a 1% chance of incapacitation per annum, it's a multi-crew situation. It multiplies out to be infinitesimally small. The chance of both pilots being incapacitated at the same time. And, if people want to Google that paper, it's by Mitchell and Evans. Both were at the CEA at the time. So Mitchell and Evans,
I will put
incapacitation risk. I mean, it's quite hard for a non-mathematician to follow, but we are actually trying to quantify risk. So in some medical conditions, the specialists will say to us, there's a 1 in 100 chance of that coming back. And if they can't quantify it, we'll look in the world literature and say, there's no information on this. We'll say to specialists, if you have 100 patients with this, how many of them do you think will come back to your clinic next year with a flare-up? 2. Okay, so approximately we're talking about 2%. Sometimes it's as subjective as that. But where there's scientific evidence, so in a lot of cancers, there's very, very good survival stats, and we can use those to work out an incapacitation risk. So if somebody's got a relatively benign cancer that's been treated and they're being followed up for recurrences and that, then they'll get a classic example is prostate cancer in men, because it's so treatable and it's so easy to monitor, that there's so many pilots flying with that, because the risk is very, very low. And as long as the risk is low, you can have as many medical things as you want going on, as long as they're all under control and the risk is low. Because everyone's got medical stuff. It's almost unheard of for somebody to come in and not take anything.
Makes sense. Yeah. There is also a few questions that members have asked in terms of ECGs and audiograms and what the requirements are for this. And there's a good question and one that I can also relate to. If you've had an ECG recently by the NHS or your GP, for example, can this be used to prove a point of a medical case at your class 1 instead of potentially doing it with you guys at Heathrow Medicals? People are just thinking of the cost, I think, in terms of that question.
No, unfortunately not. Unfortunately not. There's a variety of reasons for that, but the main reason is the CA won't allow it. So we have to put the electrodes on that person, and we have to do the ECG. We have to use a certain brand of ECG machine with a certain software, and it has to be calibrated regularly and all that. If somebody brings in an ECG from outside, well, number one, there's no guarantee it's their ECG.
Yeah, of course. Yeah.
Because people do these sort of things. They can take their mate along and they bring the mate's ECG. It's happened, and we know it's happened because we've got examples of it. But also it might not have been done on a calibrated machine or the right machine that's CA. So we have to do it. So that's a common thing. Can I shave some cost off it? What we do, we're not choosing to do. We're doing it because that's the rules.
Of course, like everything else, isn't it? Yeah.
Yeah, it's just that's the rules.
Sure. If individuals, for example, come to you and you have to award them the class 1 with a restriction, for example, the option that we were talking about before, the multi-crew only, how does this affect your chances of getting employed as a pilot at the airlines, for example? Like what is the chance of an airline selecting a candidate with no restriction to one with a multi-crew only?
Okay, that's a great thing. So first of all, just to be sure we understand, though, that we can't here in Heathrow issue with anything other than a spectacle limitation. That's the only one we are allowed to apply. All the others are applied by the CAA. We would refer, and they can't issue with an OML, a multi-crew limitation at an initial, but they've got a sidestep maneuver, the SSL NCAT, ILA NCAT, it's called no commercial air transport, that allows the person then to go on and later get an OML when they've got their license. I have heard anecdotally, so I've heard people have come to me and I talked to a lot of pilots, that if there's two candidates and they're both equal in all other way, that OML will say, well, that makes the choice then. I've heard that. So people don't like the OML. The pilots don't like it. I'm not sure if that's true or if it's urban myth or not. But it seems odd to me because we're moving to a world where virtually no one flies single pilot. A few helicopter pilots maybe, but in the commercial air transport world, it's all multi-crew. We're looking at multi-crew licenses. And it may be that in the fullness of time, we'll move to multi-crew medicals only, because that's all there is. There's only multi-crew. But at the moment...
I guess the only single pilot operation maybe is those flying cargo or freight at night on a turboprop, for example.
There is. I heard there's an airline that flies to the Scilly Isles where there's one pilot. It's a very small airline. Because even if you go on the up to Barra from Glasgow on the Loganair flight, there's two pilots. But somebody told me there's one fixed wing single pilot commercial operation, and I've never checked it out. in terms
Then
of passenger transport.
Sure, the ones that operate in the Ciliars operate Britten-Normans, and as far as I'm concerned and that I know of, they do operate multi-crew.
Then things have changed.
So,
then there's no. I don't
yeah.
think there's any passenger transport multi-crew other than helicopters now.
Right. Oh yeah, someone is saying Skybus and Loganair in the Britain. Yeah, they operate Britten-Norman. Okay. So Skybus and Loganair are the two airlines that operate the Britten-Norman Islanders, and they are single pilot. So there you go. Those are the ones that you were probably thinking of.
Yeah, I mean, my point is that it's very rare.
Sure.
And it's mostly multi-crew. So you read in the flight magazine and so on, we're moving to multi-crew licenses. Why aren't we moving to multi-crew medicals? But in a sense, the medical always lags behind. So it might be several years before revisions are made. At the moment, the starting point is most people want to be able to fly commercially single pilot, even though that's a very rare event. And so having a multi-crew, people don't like it because it sets them apart from other people. It's a stigma, if you like. But the other way of looking at it is without it, you'd be grounded. So we look at it as a way of keeping people flying who would otherwise be grounded. We're doing you a favor, but the person receiving it doesn't always see it as a favor. They see it as a stigma, something that distinguishes them from their colleagues and not in a good way. But basically, some things that would have been end of career, like heart attacks, you can only ever fly multi-crew after that, and only after 6 months, and only after you fully recovered. Previously, that was the end of your job. If you had a heart attack, you could be in your 40s, and one of the unlucky ones have a heart attack. That was it, game over. Better hope you're trained to do something else as well. So we see the multi-crew as a kind of benign, kind thing, but the recipient doesn't always see it like that for the reasons.
Of course, yeah.
There were a few questions here. Do you want me just to skim through them and see?
Absolutely, feel free.
There was one.
I'm sure there would be loads that would be applicable to us. So feel more than free, Dr. Betts, no problem.
So Chris W's asked, quite a few integrated programs require an FAA Class 3. Are there any medical referrals to this FAA more straightforward if we already hold? So it's a different process. In a way, it's starting again. The fact you've passed one, you can pass one and fail the other in either direction. Okay, but what does help is if you're having them on the same day and you need an ECG for both, then the ECG can be billed, for both. So I'm a contractor here. I come here and I get paid for the day and I see 6 pilots. I don't do the billing, but I believe that where there's overlap, there's an economy of doing them. It's more straightforward in that way. And when I do renewals in my own practice, so I'm Pilot Medicals, I'm Central London, I'll discount the person if they're doing a renewal and they do both at the same, because you can't bill somebody for one ECG twice, right? You can upload it to both. It's no big deal. But the fact that you passed the Class 1 doesn't mean CA doesn't mean you'll automatically pass the FAA, because the visual rules are different. For example, you could theoretically fail the FAA but still pass a UK Class 1. Because there's subtle differences in the rules. Yeah,
it's similar, isn't it? For example, when you get military pilots that have come straight out of the MOD, for example, or the RAF, who are going into a commercial career, who, yes, they've passed the RAF requirements, for example, but they think that they could pass a Class 1. Have you ever got cases as such that they potentially have passed an RAF medical, but they come to you and they're unable to pass a Class 1?
Yes.
Yeah, I've
because the rules are different.
Yeah, of course. Yeah, different regulating bodies operate differently, isn't it? So,
but the overwhelming people pass because there's usually a fallback plan, right? So if the blood pressure's high, you do a 24-hour tape, and if that's high, you get treated, and then you get the tests, and then you're back flying. So that most things can be fixed. It's not like a pass-fail exam or stuff like that. It's a risk assessment. Now, somebody's asking, can fatigue be disqualifying even if it's manageable? So fatigue to me is a temporary state. It recovers if you rest. So we see fatigue in pilots, and we're supposed to be aware of it and ask the pilots at the renewal medicals. And we can make people temporarily unfit if their managers are bullying them into flying punishing schedules that are contributing to we can say, right, that's not safe, you're unfit. So we find a way of making them rest, basically. But fatigue's a big problem. Ian Mullen, who works here part-time as an AME, he is an active RAF doctor. He's an expert in fatigue. So he's a researcher in fatigue and flying rosters and adjusting flying rosters to minimize fatigue. But you guys all know that, you can be flying at very early in the morning or very late at night across time zones. So fatigue management's a huge thing. But it should not be disqualifying, to answer Abigail Gregory's question. Should not be disqualifying.
Sure. In terms of the question, Dr. Pitts, I think they're all the questions. We've covered a lot of subjects this evening. Unless there are any more, the last kind of subject that I did want to cover was what is the jump like from someone who was a Class 2 to coming to you guys and getting a Class 1 medical?
Oh, so the one thing to remember there is if there's an issue that comes up, your Class 2 is suspended while your Class 1's being worked out. Some people get a bit of shock about that because they've planned a flying holiday or something.
Yeah, I didn't know that actually, but yeah.
No, so they jocularly referred to that as the CAA as your investment may go down as well as up. Okay, so you'd be happy flying in the Class 2, but you've got a condition that needs worked out for commercial. The rules are different for Class 1 and Class 2 for asthma, for example. So your AME may have been happy and you've got asthma and it's controlled and you get your Class 2 and off you go. You pitch up for your Class 1. Sorry, we need a consultant respiratory and do the provocation tests because we're now at a higher altitude and pressurized cabins. And they say, oh, you say, well, sorry, your Class 2 is suspended till you have that. Because the risk is now unquantified. So once the Class 1's referred, the Class 2, LAPL, everything's referred. So nowadays it's not so bad because the CA are really good at turning cases around now. So if the person gets the report in a couple of days, the CA might turn it around in a week. They miss a week's flying. But we have in the past, when it's been a much longer period, of latency, had people bitterly complain about that because they weren't aware of that. Somebody's asked about generalized anxiety and burnout. Positive record of recovery. That should be okay. I mean, just talk about it. We declare it. We're compelled to ask you to get a psychiatric opinion, and you might want to release your therapy records from the time or get a report from the therapist. Ears and hearing we've covered. Eyesight. All of the actual requirements. If you want the numbers, just go on the CAA website. And it's actually quicker to Google it, CAA eyesight, than it is to go on the website and search through till you come to numbers. And similarly for the FAA, Canada, Australia, it's all online now.
Sure. I mean, in terms of the coverage of kind of achieving a Class 1, like you said, there is a lot of information on the website. But am I right in saying that if people had any further questions after this evening's webinar, would they be okay to email the centre directly with?
Yeah, so email medicals@heathrowmedical.com. I would just call it general query following webinar or something like that.
Sure.
And we'll so I I'm at Pilot Medicals, and I get quite a lot of people giving me class 1 inquiries, but I just say to them, look, you have to actually, the conduit has to be through the Aero Medical Centres. So I might know the answer to the question, but I say you've got to ask the question through the Aero Medical Centre because you're class 1 initial, and I might be the guy answering it, but it has to come through the Aero Medical Centre.
Right, yeah, that makes more sense now in terms of what the process is and what it is to achieve it. In terms of this evening school, I think we've covered all the questions, but this webinar has also been recorded for the people that cannot attend this evening. All I can say, Dr. Pitts, is thank you very much for your time this evening. It really has been a great pleasure to have you here and answer our questions.
I'm so grateful for the opportunity. It's been a real pleasure to help a little bit, and by all means send in your questions afterwards. And if you want us to do this again, we're more than happy. It's been great.
Perfect. Thank you very much, Dr. Pitts, for your time.
Thank you so much. Thank you. Bye-bye.
Bye-bye. Bye-bye.